the talk today is on WHO Group 2 pulmonary hypertension, and this is an overview of pulmonary hypertension due to left heart disease. So the objectives, the goals by the end of the talk, to understand the basic function of blood flow of the heart, how blood comes in, how blood gets to the lungs, and then how blood exits the lungs and returns to the heart. Understanding all of these are critical to get a sense of group 2 pulmonary hypertension. So recognize problems and diseases with the heart related to pulmonary hypertension. What type of disease processes of the left heart may lead to pulmonary hypertension? Understand how these diseases can lead to pulmonary hypertension and maybe why sometimes pulmonary hypertension develops and other times it does not. Get a basic sense of some of the tests commonly used to diagnose left heart disease. These are tests that your doctor may order for you or may repeat once you have a diagnosis for monitoring. Again, describe the tests most commonly used to diagnose left heart disease, and discuss the current treatment paradigm for people with group 2 pulmonary hypertension, and in particular, understand some of the differences between group 2 pulmonary hypertension and group 1 pulmonary hypertension, which is pulmonary arterial hypertension. And finally, give some recommendations for questions you can ask your doctor to ensure that your treatment plan is proceeding as expected. And if symptoms persist or don't improve, get an idea of what you can ask your physician. Okay, so for all types of pulmonary hypertension, but specifically group 2 pulmonary hypertension, it's critical to have an understanding of the heart chambers and valves and how they work. So the goal of the heart, and I think we've learned this since we were children, is the heart is a pump. It is one of the strongest pumps in the body. But importantly, the heart actually has two pumps. There is a pump on the left side, which is the left ventricle. The goal of this pump is to deliver blood to the body. That's oxygen-rich blood. So the organs of the body, your brain, your liver, your kidney, and your muscles can get the oxygen they need to function properly. So the blood that goes through the body then returns through veins. The veins take the blood after the oxygen has exited into the muscles or the bed that they're delivering to, and then returns to veins into the right side of the heart. It returns then to get pumped back into the lungs where carbon dioxide is exchanged for oxygen. What are the purposes of the heart chambers? The chambers on the top of the heart, which are the atria, function as reservoirs and passively accept the blood and deliver it to the ventricles. The right ventricle pumps the blood into the lungs, and the left ventricle pumps the blood to the body so the organs can then get the oxygen that they need. And this is a schematic of a heart here, and blue is reference to deoxygenated blood. That means blood that has gone to the body and is now returning, having delivered the oxygen that the body needs. So it returns via the veins to the right atrium, there on the left side. The blood then flows through the tricuspid valve into the right ventricle on the bottom. And then the right ventricle pumps this blood into the pulmonary artery, which then goes through to the lungs. So the blood travels through the lungs and goes through tiny little capillaries where oxygen and carbon dioxide are exchanged. And then after the blood becomes oxygen rich, it turns from blue to red. And we know this when we look at the veins in our body. They're blue when we look on our hand. And this red blood returns to the left atrium and then crosses the mitral valve to the left ventricle. And then this is then pumped out to the body. So when we are talking about pulmonary hypertension due to left heart disease, group 2 pulmonary hypertension, we are emphasizing the right side of this figure here. So that is the left ventricle, that is the left atrium, that is the mitral valve. And there are disorders of these structures which primarily lead to group 2 pulmonary hypertension. And this animation here shows you how blood flows, how it transits when it returns from the body through the right ventricle, through the pulmonary artery, and then when it returns to the left atrium into the left ventricle. So, what heart diseases and problems cause group 2 pulmonary hypertension? So, there are two types of heart failure. The first is left ventricular systolic dysfunction, which is termed heart failure with reduced ejection fraction. And this is a type of heart failure we think about where the heart may become enlarged or dilated and the pump becomes weak. So, the pump just pumps a fraction of the blood that it's normally supposed to. We see this sometimes following a heart attack. We also see this sometimes when, for causes we don't identify, the heart may enlarge. The second cause is left ventricular diastolic dysfunction, or heart failure with preserved ejection fraction, or HFpEF. This is a little bit harder concept to understand, but is equally important because with age, and particularly more common in females, and with high blood pressure and diabetes, HFpEF becomes very common and is a common cause of group 2 pulmonary hypertension. In this case, the heart muscle is not weak. It is oftentimes not enlarged, and it pumps a good amount of blood. The problem with HFpEF is the heart muscle becomes stiff. It does not relax properly. So oftentimes when a patient is seated or not active, they do not have symptoms. But anytime a little bit more activity is required with walking, particularly up an incline or climbing stairs, when the heart has to pump more blood, it is unable to relax. It cannot enlarge or dilate to accommodate more blood flow, and this causes the pressure to rise and shortness of breath to develop. So the final item here is valvular heart disease, and there are two valves on the left side of the heart which can, abnormalities can lead to pulmonary hypertension. The first is the mitral valve. If you remember from the prior slide, the mitral valve separates the left atrium from the left ventricle. When the valve is open, blood flows from the left atrium to the left ventricle. Then when the left ventricle starts to pump, the mitral valve needs to close, so the blood will flow properly out the heart through the aorta. If the mitral valve becomes narrowed or stenotic, this can occur with calcification, this can occur via thickening, there is an impediment to blood flow, and this can lead to stenosis. If the valve is damaged and it does not close properly and becomes leaky, this causes mitral regurgitation, and blood flow, instead of when the ventricle contracts crossing the aorta to go to the body, can go backwards into the left atrium. Both of these conditions may lead to pulmonary hypertension. The second valve is the aortic valve that separates the left ventricle from the aorta. So when the left ventricle needs to contract to eject blood, the aortic valve has to open in order for the blood to flow from the left ventricle to the aorta. If this valve is narrowed, it impedes blood flow from the left ventricle to the aorta, or if the valve is leaky, meaning when the aortic valve is closed, instead of preventing blood flow from the aorta to the left ventricle, if there is regurgitation of this blood, this may over time cause the left ventricle to become enlarged and can also lead to pulmonary hypertension. So here is a schematic describing systolic dysfunction or heart failure with reduced ejection fraction, and diastolic dysfunction, heart failure with preserved ejection fraction. On the left, you can appreciate that the left ventricle is enlarged, a little bit dilated, and this heart muscle is weak, and so this ventricle may not be pumping enough blood, and this is systolic dysfunction. On the right-hand side, the left ventricle is not enlarged at all. In fact, if you look at the walls of the left ventricle, they appear thicker, and this is called hypertrophy. We see hypertrophy if patients have disorders that cause infiltration of the heart muscle to make it thick. We see this sometimes with kidney disease, diabetes, and sometimes if hypertension has been present for a long time and not adequately controlled. And those are all risk factors for diastolic dysfunction or heart failure with preserved ejection fraction. So two very different types of heart failure leading to group 2 pulmonary hypertension. So One of the questions that comes up is how common is group 2 pulmonary hypertension? And for patients with a diagnosis of pulmonary hypertension, group 2 PH is the most common form in the United States. So this is important to recognize that when someone says they have pulmonary hypertension, and they may be on very different treatments, different patients, and it's because they may have different groups. So as a cardiologist practicing, when I see patients referred for pulmonary hypertension, group 2 pulmonary hypertension is most common. And you can appreciate this slide, group 3 pulmonary hypertension and group 1 pulmonary hypertension are significantly less common. And this is largely because risk factors for group 2 pulmonary hypertension, high blood pressure, increasing age, diabetes, are all becoming more common across the world. So the question that comes up is how and why do these heart problems cause lung problems and pulmonary hypertension? So to answer this, you must recall the heart and the lungs are intimately related in that the blood flow from the right side of the heart goes to the lungs, where gas exchange occurs and oxygen comes back into the blood, and then returns to the left atrium to the left ventricle. So this is why disorders of one organ, the heart or the lungs, can then lead to problems with the other organ. So specifically, disorders such as HFrEF or mitral valve disease or HFpEF can cause pressure or volume increases in the left side of the heart, the left ventricle, then the left atrium, and this elevated left atrial pressure is then transmitted back into the lungs and is manifested clinically as shortness of breath, and we see this as pulmonary hypertension. So this diagram here illustrates the very close relationship of the heart and the lungs. And we can appreciate that the left ventricle, the thicker muscle, if pressure elevation occurs in the left ventricle or the left atrium, you can appreciate how that would be transmitted backwards into the lungs, which would then lead to pulmonary hypertension, which then can lead to pressure elevation on the right side of the heart, enlargement of the right side of the heart, dysfunction of the right side of the heart, which may then lead to enlargement of the right atrium, which could cause problems with the venous return, and this is oftentimes seen with swelling, and our patients may have swelling in their legs or their belly. So this slide here shows a very close relationship of the heart and the lungs and should provide an understanding why problems with one side of the heart can affect the lungs and can ultimately be transmitted to the right side of the heart. The other thing you will appreciate in this slide is that the left ventricle and the right ventricle share a common wall, which is called the septum, that separates the two chambers. And so if one chamber, specifically the left heart, enlarges, or if that septum hypertrophies or does not contract properly, we can appreciate that will cause dysfunction of the other chamber or the right ventricle. So these are important concepts, understanding why left heart disease can affect the lungs as well as the right ventricle. So diagnostic testing in pulmonary hypertension, what imaging studies would your doctor want you to have completed? So a chest x-ray is required for all patients suspected of having pulmonary hypertension, and this will help us understand if there is primary lung problems, or can sometimes disclose enlargement of heart chambers or tell us if there's fluid in the lungs, which we call pulmonary edema, which may point to different causes of pulmonary hypertension. The electrocardiogram, or EKG, is something routinely performed in all patients. And the EKG will also tell us, provide some clues, is if there is hypertrophy or thickening of the left heart, as well as chamber enlargement. Importantly, enlargement of the left heart structures is not routinely seen in pulmonary arterial hypertension. The echocardiogram, or heart ultrasound, is the most valuable test and is mandatory for all patients suspected of having pulmonary hypertension based on symptoms. The heart ultrasound will give us exact measurements of the systolic function, how well the heart is pumping, and we can also use some sophisticated measures on the echocardiogram measuring how fast blood flows through the heart and how fast the heart is squeezing. By measuring these speeds or velocities, we can help understand the severity of lesions of the valves, as well as problems with heart relaxation or heart failure with preserved ejection fraction. It's important to appreciate that the echocardiogram is not sufficient to make a diagnosis, even when there are strong findings suggestive of HFpEF or group 2 pulmonary hypertension. Right heart catheterization is mandatory. This is an invasive procedure performed in the laboratory where a catheter is inserted into a vein, and this catheter then goes through the vein into the heart and measures pressures, measures how much blood flow the heart is pumping, and allows us to measure the resistance of blood flow in the lungs, all parts which are critical in determining the specific type of pulmonary hypertension and developing a treatment plan. In some cases where the diagnosis following catheterization is unclear, the physician performing the procedure may recommend either exercise testing or a fluid administration, which may help further clarify the type of pulmonary hypertension. So what are the treatments for pulmonary hypertension with left heart disease? A common cause which underlies all of medicine, irrespective of the type of pulmonary hypertension, is determining the specific cause and treating the cause if possible. So let me talk a little bit about this. If the problem is the mitral valve, understanding, can the mitral valve be fixed? Can it be fixed with a catheter, or does it need open heart surgery? If the problem is with heart stiffness, trying to understand why. Is the problem related to blockages in the heart arteries? And in fact, can those arteries then be repaired with either a stent or a heart bypass surgery? So these are looking for potential causes that we could treat the underlying cause. There are some principles which apply to all patients with group 2 pulmonary hypertension, irrespective of the cause. There needs to be a careful balance between sodium and fluid intake. Most disorders that affect the heart and the lungs, patients become very salt sensitive. Even small or medium amounts of sodium, the amount of sodium which was in our diet when prior to developing pulmonary hypertension, can cause fluid retention, can cause blood pressure elevation, and can make patients become much more shortness of breath. So being very cognizant of our dietary choices and reading the food packages is essential. As well as if fluid retention or swelling is part of the symptom complex, we become very aware of the fluid intake, how much we're drinking, as well as if patients are on diuretic medications, which help them pee out excess fluid, being cognizant of how much we're drinking so we can achieve an even fluid balance. Additionally, monitoring the systemic blood pressure. So we talk a lot about pulmonary hypertension, that's what we've been talking about, but your tried and true blood pressure, the one you've been getting since you were a child, where the doctor inflates the cuff on your arm and puts the stethoscope over your arm to measure the blood pressure, it's very important to monitor the systemic blood pressure. There are problems if it's too high, and there can be problems if the blood pressure is too low. So your doctor may regularly check the blood pressure and may actually have you check it at home so that the medication treatment plan is optimal. In most cases, medications that we use for pulmonary arterial hypertension or group 1 pulmonary hypertension are not recommended. Studies have been done in several medications which are FDA approved for group 1 pulmonary hypertension. Some drugs have been shown not to have benefit in group 2 pulmonary hypertension, and some other drugs have been shown to cause harm. So it is important to appreciate that as of 2019, there are no PAH drugs which are FDA approved for treatment of group 2 pulmonary hypertension. So this is important. So in your own research or understanding pulmonary hypertension, if you come across these drugs and may wonder, why is my physician not prescribing them for me? It's because your physician is determining what group of pulmonary hypertension you have and then describing a treatment plan based on the pH group. It's important to appreciate that patients with group 2 pulmonary hypertension may develop profound pressure elevation, and the degree of pulmonary hypertension or the magnitude of elevation is oftentimes not helpful in discriminating between pH groups. We also understand that with group 2 pulmonary hypertension, if it's long-standing, and in some specific groups, there may be changes in the pulmonary arteries which are similar to those seen in group 1 pulmonary hypertension or PAH. In certain cases, this can be a very difficult diagnosis to make. And in these cases, when the doctor is doing the heart catheterization and is measuring the pressures, they may prescribe an exercise test, and this is done differently. Some hospitals use a bicycle that patients pedal at the time of the heart catheterization, either on their back or sitting up. Occasionally, when the test is being done, the doctor may give a fluid challenge, administering a large amount of saline through an intravenous line and monitoring the response of the fluid levels and the pressures in the heart. These changes in pressure may help differentiate between group 2 pulmonary hypertension and group 1 pulmonary hypertension. So, some follow-up recommendations for people with group 2 pulmonary hypertension. So, what should a patient expect in a follow-up visit? As we mentioned, monitoring of blood pressure, fluid status, and symptoms is critical. The doctor will ask about what activities you're able to do, how far you're able to walk, and may perform a 6-minute walk test to determine your activity level. They will check when they examine you for evidence of swelling or fluid retention in your neck veins, your belly, and your legs. And they will also check your blood pressure and may request you to monitor your blood pressure at home to ensure that it is not too high or too low. Especially with diagnosis, and if diuretic medicines are initiated, laboratory studies may be monitored. These are important to monitor kidney function and electrolyte levels. Diuretic medicines as well as blood pressure medicines may affect these parameters, and if potassium levels get too high or too low, they may cause heart rhythm problems or arrhythmias. So these are routine parts of the office visit for group 2 pulmonary hypertension. How often are these visits performed? More frequent follow-up is usually prescribed initially. During these first few visits, there's more diagnostic testing being performed. There is titration and adjustment of medications, both blood pressure medicines and diuretics, and patients may be modifying their diets. So during these visits, during these times, visits may be occurring on a monthly basis, every 3 to 4 weeks. Once we achieve a stability phase, where less frequent medication titration is performing, and when the fluid status is optimized, these visits may space out to every 3 to 4 months. Much of the diagnostic testing that we described only needs to be performed once on diagnosis. Once the diagnosis is established, there is less frequent testing for monitoring. This may be the 6-minute walk test, occasionally the echocardiogram, dependent upon the type of group 2 pulmonary hypertension. Mitral stenosis or mitral regurgitation may require more frequent monitoring, and heart failure with reduced ejection fraction may not require the echocardiogram be performed as frequently. So, questions to ask your doctor when you come to your office visit, and these are important. It is very important to tell your doctor if you are not feeling better. As thorough as the physician aims to be, and despite all of our diagnostic testing, we sometimes may not have the right diagnosis. So if the treatment plan isn't working, you need to tell your doctor. If the shortness of breath is worse, if the swelling is worse, if you have new symptoms following the initiation of treatment. This will lead the doctor to reconsider whether more diagnostic tests are indicated and whether the treatment plan may need to be modified. Oftentimes, the right diagnosis is identified by prescribing a treatment plan and assessing the response and then changing the treatment plan to determine a diagnosis. Pulmonary hypertension comprehensive care centers have an interdisciplinary program which is valuable and has expertise in determining the right diagnosis. The second is side effects to treatment. Blood pressure medications, valvular heart disease treatments, diuretics may all have different side effects. These may affect the blood pressure differently, causing low blood pressure and dizziness. They may cause cough, they may cause sinus congestion, and they may cause swelling. A large part of a physician's practice is side effect management and working with our patients to ensure that the treatment can be tolerated. So notify your doctor if the treatment plan is causing you to have side effects, and especially if you're feeling worse. Next, are there research studies available? As we mentioned, for group 2 pulmonary hypertension, we try to find the cause. If the cause is mitral valve disease, aortic valve disease, we try to treat the underlying cause if possible. If the cause is heart failure with preserved ejection fraction, or HFpEF, we do not use pulmonary arterial vasodilators routinely because they have not been shown to be effective. However, this is an area of active investigation and active research. And many comprehensive care centers may have ongoing research studies available for patients with different types of group 2 pulmonary hypertension. These may be larger clinical trials, which are phase 3 clinical trials involving multiple sites all across the country, or they may be smaller studies, phase 2 clinical trials, looking at a smaller number of patients. So it's always worth asking, are there any research studies available? Would you qualify? And if you do qualify, is this something that you would be interested in participating in? And finally, what can you do as the patient to help your pulmonary hypertension? And this can take the form of support groups. There are support groups regionally all across the country, and tapping into a support group community, patients similar who have shared experiences and have gone through the evaluation process and treatment may provide some comfort and guidance. Is rehabilitation an option? Depending on your symptoms and if there's been a hospitalization. Is cardiac rehabilitation an option? This is a structured exercise program where your blood pressure and heart rate are monitored. There are sessions on diet and lifestyle so that you can regain confidence and lead to a healthier lifestyle. And finally, what can you do as a patient to advocate for yourself for your own pulmonary hypertension? Inquiring about local support groups. Support groups are invaluable, identifying patients nearby who have shared experiences, who are living with pulmonary hypertension, and you have gone through the evaluation and treatment process may provide comfort and insight. Identifying if cardiac or pulmonary rehabilitation may be an option. These are structured exercise programs, usually performed 3 days a week, where a trained exercise professional will monitor your heart rate, your blood pressure, your oxygen level, and also include teaching sessions regarding diet, lifestyle, and healthy choices. Oftentimes, rehabilitation involves like-minded patients who are motivated and relationships are built, and it provides a transition to a healthy home lifestyle. Many patients, after doing rehabilitation, find that they want to continue the exercise programs themselves once they graduate from the class itself. Finally, we have more and more emphasis on self-care, identifying what as a patient you can do to help yourself. And things we focus on here are our dietary choices, monitoring our weight carefully, regularly, our fluid intake, our salt intake, and checking our blood pressure at home. So things we can do when we're not in the doctor's office to ensure that we're doing everything possible for our pulmonary hypertension.